I am Stina Klemming, neonatologist in Sweden. I've been part of a randomized controlled trial on immediate skin-to-skin contact for very preterm infants, and I have shared the work on the Swedish national guideline on immediate and uninterrupted skin-to-skin contact and mother-newborn couplet care for zero separation. I will give you a brief overview of this. I have consent from parents for all photos and films. I am a member of and a NIDCAP trainer in the non-profit membership organization NIDCAP Federation International, and this is an important foundation for my work. The WHO updated their guidelines for the care of the preterm and low birth weight infant in 2022. New and strong recommendations state that all infants from gestational week 28 and 1,000 grams should have skin-to-skin contact as soon as possible and continuously for as much as possible. In the implementation strategy document from 2023, the WHO also envisions for healthcare services to be reorganized around the mother-newborn dyad and the family as an inseparable center in zero separation. And as stated in the WHO position paper also from 2023, this requires a radical rethink. For a long time, the place for the preterm or low birth weight newborn was thought to be the incubator, and neonatal units have been structured around the incubators, and parents and families were not central. And new units actually look the same, only with nice colors. We now know that this is a toxic experience for a newborn, since the only biologically right place for a newborn is the mother's body, and the family is central for the care of a newborn. Parents have the primary role of providing physical, emotional, and social care of their baby, and actually provide the place of care in skin-to-skin contact, also when babies are born small or sick, and combined with needed care and technology. Zero separation is the most important developmentally supportive intervention for all newborns, and it is the best interest of the child. There are ways to do this change in clinical practice, with a change in mindset and some important but minor changes in our ways of working. In September last year, we published the Swedish National Guideline on Immediate and Uninterrupted Skin-to-Skin Contact and Mother-Newborn Couplet Care. This guideline was developed through the Swedish Association of Local Authorities and Regions in a collaborative process with healthcare professionals from neonatal care, obstetrics, anesthesiology, and intensive care, and we had a patient representative. I co-chaired this large multi-professional group. The guidelines state that mothers and their newborns, term and preterm, are cared for together regardless of medical needs and complexity in couplet care, with early or immediate initiation of uninterrupted skin-to-skin contact during the first hours after birth. In the guideline, our definition of couplet care is that two patients receive their care together. The mother and the newborn receive their care in the same unit and in close physical proximity to each other. This is recommended from birth for all mother-newborn dyads, regardless of gestational age, also when the mother, the newborn, or birth need specialized care. The care of the two patients is located in the unit that is responsible for the patient with the most complex medical needs. Couplet care is a way to keep mothers and newborns together during the first hours and days when the mother is still a patient in the hospital. When either the mother or the newborn is discharged, care is no longer defined as couplet care. Initial uninterrupted skin-to-skin in the guideline is defined as skin-to-skin contact as soon as possible and during at least the first 2 hours. Immediate skin-to-skin contact is evidence-based for infants from gestational week 28 and about 1,000 grams, and the clinical practice and recommendations in the guideline is very much based on our experience from the study IPISTOS, Immediate Parent-Infant Skin-to-Skin Study, that I was part of. At Karolinska in Sweden and Stavanger in Norway, we randomized 91 very preterm infants before birth to either immediate skin-to-skin contact with the parent or conventional care in an incubator for the first 6 hours after birth. We showed improved cardiorespiratory stability, stable thermoregulation, improved early connectedness and bonding between parents and newborn, and improved parental mental health, as well as improved social competence in the infant at 4-month corrected age. More publications will follow. Our study confirmed previous findings and the rationale from nurture science about resilience and health, and it supports the theory of a critical period directly after birth. We conclude that immediate skin-to-skin contact is feasible and safe and should be the desirable standard of care also for very preterm infants. Stabilization and newborn care and zero separation in the birth room need to be planned well, but it's really not different from our regular care. The care is the same, the place is different. We inform and support parents. We need equipment and NICU staff to be in the birth room. We need the equipment to be connected to gases and power supply, and we need good communication within and between teams, and a calm atmosphere. Respiratory support and monitoring, as well as temperature-controlled tubes, feedings, lines, and fluids for the newborn are planned as usual, only the place is different. And we continue neonatal care in the same room as the mother and in skin-to-skin if possible. We need to go mobile, with mobile skin-to-skin compatible equipment, with everything we need mounted for the care of the newborn, as you see on this list. We also need an adult bed for the mother, a wheelchair for the other parent, and maybe a birth trolley, either locally put together equipment or a commercially available one. Birth trolleys were invented for stabilization and resuscitation on intact umbilical cord. And the platform on the trolley add a welcome backup plan for the place of care to increase safety for our patients in all situations. Birth trolleys are perfect to use as our mobile equipment when the baby is cared for in skin-to-skin contact and not on the platform, here in the operating room and during transfer. Here we see immediate skin-to-skin contact for a very preterm infant in the immediate parent-infant skin-to-skin study EPISTOS. This boy was born with a C-section in week 28 plus 2, weighing 1,052 grams. He was put in immediate skin-to-skin with a surrogate, the sister of the mother, and got all the conventional care with nasal CPAP monitoring and temperature control. The place was different, the care was the same. A recommendation for C-sections is that the mother's chest and one arm should be free for the mother to be able to have her newborn in immediate skin-to-skin contact. We also recommend that pain, nausea, and hypotension in the mother should be actively prevented so that the mother can be comfortable in skin-to-skin contact with the newborn on her chest. For very preterm infants born with C-section, it might be difficult to manage immediate skin-to-skin contact with the mother, and instead the baby can be placed in skin-to-skin with the other parent. This girl in the EPISTOS trial was born in week 28 and 4 days, weighing only 965 grams. Immediate skin-to-skin contact is possible also for twin birth. This was a vaginal preterm twin birth in week 31. After the cord was cut, twin 1 was put skin-to-skin with the father and received care with nasal CPAP monitoring and eventually also nasogastric tube and a peripheral line. Twin 2 stayed with the mother and received care there. Care was the same, the place was different. As we see here, we had double sets of mobile equipment, and initially we had 2 neonatal nurses. One nurse stayed with the family in the birth room for 2 hours. 45 minutes after delivery, the mother started to hand express milk, while twin 2 was still in skin-to-skin with the mother. It has been shown that for the best breastfeeding outcome, the first suckling of the newborn or hand expression need to happen during the first hour after birth. To give the best conditions for the initiation of breastfeeding, we recommend to postpone routine care of the newborn, such as measuring and weighing, until at least after the first 2 hours of uninterrupted skin-to-skin contact, whenever possible, to support the 9 stages of instinctive breastfeeding behaviors. Most motivated procedures and interventions, medical checks and treatments for sick, small or preterm newborns can be done without interrupting skin-to-skin contact and with continued good temperature control. If we stay in the birth room until the mother can be moved, we can transfer the mother and the baby together using a bed for the mother, as seen in the pictures below. When this is not possible, we facilitate connection between the mother and the newborn through a period of skin-to-skin contact, holding, touching, smelling, and then we transfer the baby with the father, the other parent, or a surrogate. The mother comes when stable enough according to local guidelines. Many units in Sweden now have an adult bed for the parent in the NICU bed space, both in intensive care and in family rooms. Many units don't even provide a baby bed or an incubator, but care for the infant on the parent or next to the parent when the infant is in therapeutic hypothermia. A KMC binder should be used to support a safe fetal position and secured airway, preventing obstructive apneas, so that parents and monitored babies in the NICU can have safe, continuous skin-to-skin contact day and night, also when sleeping themselves. Zero separation after the first hours is usually only possible if we have a specific organization for couplet care implemented. There has been only a few publications of specific models for zero separation through Mother-Newborn Couplet Care. There are publications from Sweden, Canada, the Netherlands and Finland, as well as the countries in the immediate KMC study, India, Malawi, Ghana, Nigeria and Tanzania. There are several ways to organize Mother-Newborn Couplet Care. In Sweden we have identified 4 different organizational models. I will describe the differences. Model 1 has separate departments for neonatology, obstetrics and anesthesiology, and the staff in these units care for their patients sort of regardless of the other teams, but of course in collaboration. Model 2, midwives for postpartum care of mothers are employed in the NICU and are part of the NICU team, which gives the family a primary nursing team. Model 3 is specialized newborn care for moderately sick and late preterm infants in the maternity ward. This is implemented in all units in Sweden and many other countries and has partly been driven by lack of beds in the neonatal units. Model 4 is the most interesting and novel model, with a department of perinatology with care for all mothers and all newborns in one organization, organized around the mother-newborn diet as an inseparable center, as in the WHO vision. Regardless of how we organize staff for couplet care, we need a flexible system and we need to reimagine how care is organized. The radical rethink prompted by the WHO. Couplet care is planned in the unit responsible for the patient with the most complex medical needs. Care is tailored based on each patient's medical condition, together with the unit's capacity. We recommend a postpartum risk assessment to decide the level of care, the location of care, and the tailoring of care. Most mothers for infants in need of neonatal care will have a low risk assessment after birth and can be transferred to the neonatal unit for couplet care soon after delivery. For mothers with moderately complex medical situations, we need to individualize and tailor care for the mother, for her to safely be cared for in the neonatal unit. In these cases, staff caring for the mother need to be flexible and mobile. If the care for the mother for a few hours, or maybe up to a day or a few, is needed to be located in the birth room, the operating theatre, the post-operative recovery ward, or the adult intensive care unit, a flexible way of tailoring care is instead needed from the neonatal team, so that the infant can be cared for together with the mother in these locations. This mother needed care in the adult intensive care unit. The diet was transferred there in skin-to-skin contact and is in continuous skin-to-skin during the care of the mother. Because of a tachypnea of the newborn, a neonatal nurse followed to observe the infant and brought equipment for intensified care of the baby if needed. The newborn is also assessed to determine the level of care needed, the location of care, and how care can be tailored to prevent separation. Several units in Sweden have made detailed guidelines for the risk assessment of each patient, for tailoring of care, and for the both separate and shared responsibilities for staff. Since our financial systems are often dependent on the number of patients and treatments, we recommend that we continue to register our patients, both mothers and newborns, even when they are cared for in another location. If the teams are trained to be able to delegate tasks between them, our system becomes more flexible. All involved should know how to start first aid measures in both patients, and breastfeeding support is everybody's responsibility. A common place of separation for both term and preterm newborns is the post-operative recovery room after a C-section. Observation of the mother after a C-section can be delegated from the anesthetic team to the obstetric team for the mother to be cared for in the delivery department, maternity unit, or neonatal unit together with her newborn directly after the operation. Here we see a mother and her newborn treated with CPAP in skin-to-skin during a transfer from the operating theatre and directly to the delivery department for couplet care. This is the same mother-newborn diet. The mother has 2 peripheral lines, IV fluid and IV antibiotics. She has frequent monitoring of physiological parameters. She still has a spinal anesthesia. The baby is 30 minutes old, has respiratory support with CPAP, and has been in skin-to-skin contact with his mother from birth. We see the obstetric, anesthetic, and neonatal teams working together, and we see how the mother is examined with her newborn in continuous skin-to-skin contact. From experience in several units in Sweden, we recommend that healthcare professionals in obstetric, neonatal care, and anesthesiology have organized the visits to the other units to increase motivation, responsiveness, consensus, and flexibility between the different teams and departments. We also recommend multi-professional simulation exercises. This enables good collaborations with adequate alarm routines for the 2 patients and clear responsibility for the care of each patient. Wards and rooms of all kinds should offer a good environment for newborns, parents, and staff. Space is needed for at least 1 adult bed, and many units can actually squeeze in a bed, even if many say that they can't. Families should be provided bathrooms and family kitchen, food and other services. Staff need good ergonomics and conditions for good care hygiene. Premises need to be designed for both routine care and emergency situations, and all units should have established alarm systems and emergency equipment for both babies and mothers. Most units can get the most important conditions with not so drastic adjustments, and further improvements can be done in small steps. Single family rooms are good and most often preferred by families, but not necessary for the couplet care concept. The bed for the mother and the combination with continuous skin-to-skin contact is the most important change, as we see in these couplet care units in India and Tanzania. With immediate skin-to-skin contact and mother-newborn couplet care for zero separation, we see new parental behavior with increased participation in care, as well as prolonged and even continuous skin-to-skin contact day and night. The goal of having the parents as primary caregivers is achieved. The radical rethink comes with changes in our mindset and our clinical practice. Let's increase the number of families that, instead of the devastating experience of separation and disconnection, get an experience of zero separation and connection from the birth of the baby and onwards, as the most important ultra-early developmentally supportive intervention for the best possible development, the foundation for lifelong health, and the best interest of the child. And to say this with the voice of Gabriela Mistral, Nobel laureate of Literature 1945 and founder of the UNICEF and the Convention of the Rights of the Child. We are guilty of many errors and many faults, but our worst crime is abandoning the children, neglecting the fountain of life. Many of the things we need can wait. The child cannot. Right now is the time his bones are being formed, his blood is being made, and his senses are being developed. To him we cannot answer tomorrow. His name is today. Thank you for your attention. My email is klemming.stina@gmail.com, and I am happy to connect with you. Thank you.